Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Ever found yourself facing a patient with acute abdominal pain, trying to, sift through all the possibilities and wondering about the latest guidelines for stuff that might need surgery? We've all been there.
It's a common scenario, absolutely. High stakes.
Well, today, get ready for a deep dive. We're looking into the structured world of diverticulitis management, specifically how it works in NHS general surgery.
Yeah, and this isn't just us talking theory. We're pulling insights directly from the big guidelines. Think NICE, the Association of Coloproctology, ACPGBI.
Right, the ones we actually use.
Exactly. These give a really clear picture of current best practice, what you should be doing.
So our mission today is to give you, our listener, a concise but, really thorough understanding from that first diagnosis all the way to long-term follow-up.
Yeah, hitting the key decision points, the procedures you need to know.
Helping you navigate these cases with a bit more clarity, hopefully.
But look, before we jump right in, there's a really crucial point, a disclaimer.
Ah, yes, the important bit.
It's deep dive. It's for reference. Educational purposes only. In your actual clinical practice, you must always follow your local guidelines and policies.
Right.
Always.
Absolutely critical. Local protocols are there for patient safety. Okay, sorted. So let's unpack this. A patient comes in, you suspect diverticulitis. Where does that journey begin for us? First steps.
It really starts with that clinical assessment, doesn't it? Putting the pieces together. Typically, you're looking for pain, usually left iliac fossa, the LIF, sometimes suprapubic.
Right, the classic spot.
Could be colicky, could be constant, usually a fever, and almost always some kind of change in bowel habit, constipation, diarrhea, something different.
And past history, is that relevant?
Oh, very relevant.
Yeah.
Often they'll mention similar, maybe milder episodes before. Suggests underlying diverticular disease that's flared up.
And you've got to keep those differentials in mind, haven't you? Because LIF pain isn't always diverticulitis.
Oh, absolutely essential.
Yeah.
You're running through that mental checklist. Could it be colorectal cancer, especially a PERF, inflammatory bowel disease, or, gynecological issues in women, PID, ovarian torsion?
Things you cannot afford to miss. Vigilance is key.
Exactly. And that vigilance extends right into taking the history. Beyond the pain, you need duration, fever details, those previous episodes we mentioned. But crucially, you're probing for red flags.
Okay, like what specifically?
Things like rectal bleeding, unexplained weight loss, persistent vomiting, maybe feeling a distinct mass. These immediately make you think, hang on, is this just diverticulitis?
Right, raises the suspicion of malignancy or something else serious, changes your whole plan.
Wholly shifts the pathway. Then you move to the physical exam.
Okay, what are we looking for there? Localized peritonism in the LAF. That's pretty standard.
That's the classic sign, yes. Tenderness, maybe a bit of guarding right there. Sometimes you might feel an inflammatory mass.
What if it's generalized, guarding everywhere?
There's a massive red flag. Generalized peritonitis suggests free perforation. Content spilling into the abdomen. That's a surgical emergency, straight away.
And the digital rectal exam, DRE, still vital.
Non-negotiable, you need to do it. Assess for rectal tenderness, a pelvic mass, fullness, check for blood. It completes the picture, particularly for pelvic abscesses.
Okay, so clinical assessment done. What about initial tests? Bloods? Imaging?
Right. Initial investigations. Standard bloods first. Full blood count, looking for that raised white cell count, the leukocytosis.
Though that's pretty non-specific.
It is. But the CRP, the C-reactive protein, that's often more useful. Not just the level, but the trend. Is it shooting up despite treatment?
Good point. Tells you if things are getting worse under the surface.
Exactly. UNEs, LFTs too, check kidney function, liver, overall picture. Your analysis is simple but essential. Rule out a UTI mimicking the pain.
And imaging at this stage. You mentioned perforation.
Yes, if you suspect perforation, maybe from that generalized peritonitis, an erect chest x-ray is vital. Looking for free air under the diaphragm. Neoperitoneum, classic sign.
Got it. So with all that initial info, we start to stratify, right? Put patients into boxes.
Essentially, yeah. You're figuring out, is this uncomplicated diverticulitis, just localized inflammation? Or is it complicated? Meaning there's an abscess, a fistula, obstruction, a stricture, or that free perforation we talked about.
And why is that distinction so critical right at the start?
Because it fundamentally dictates the management. Uncomplicated, often medical management, maybe even outpatient. Complicated.
Yeah.
That signals a need for more aggressive intervention, potentially drainage, maybe even surgery. It's the crucial first branch point.
Okay, so this is where it gets, well, really interesting for management. We have our initial assessment, maybe a suspicion of complicated disease. What's the absolute cornerstone now for confirming things and guiding what we do next?
Without a shadow of a doubt, it's the CT scan with intravenous contrast. That is the gold standard.
Right. When do we do it?
Urgently. For any suspected complicated case, or if the diagnosis just isn't clear clinically.
And what does it tell us?
Everything, pretty much. It confirms the diagnosis, shows how extensive the inflammation is, and critically, it spots those complications: abscess, gas outside the bowel, fistulas, obstruction.
And it helps rule out other things, too.
Hugely important. It's crucial for ruling out underlying malignancy, which can look very similar sometimes. The CT gives us that detailed roadmap of the abdomen.
And speaking of roadmaps and severity, the Hinchey classification, that's the key surgical grading system, isn't it?
Yeah.
Helps us classify things consistently.
It absolutely is.
Yeah.
And it's not just about grading. It's a critical decision-making tool, especially for surgeons. It directly guides intervention.
So can you run us through the stages quickly?
Sure. Stage 1 is basically a small abscess right next to the colon, a paracolic abscess, contained.
Okay.
Stage 2 is an abscess that's walled off, but it's further away, maybe in the pelvis or somewhere else in the abdomen, but still contained.
Right, bigger or more distant.
Stage 3, now it's serious.
Yeah.
Generalized purulent peritonitis, pus spread throughout the abdomen, but no stool.
Still bad, but not the worst.
Exactly. Because stage 4 is generalized fecal peritonitis, free stool in the abdominal cavity. That's a catastrophe, an immediate surgical emergency.
Wow. Okay, so those stages directly link to how urgent things are.
Directly. And Hinchey II, that pelvic abscess, is a great example of how things have changed. Interventional radiology often steps in there with drainage, potentially avoiding emergency surgery altogether. Huge win for the patient.
That's a fantastic point. So CT is king. What about other tests? Scopes, ultrasound, are they relevant here?
Good question, especially about scopes. Flexible sigmoidoscopy or colonoscopy, absolutely not in the acute phase.
Why not?
Risk of perforation. The bowel is inflamed, fragile. Poking around with the scope is just too dangerous.
Makes sense. So when do they get done?
Usually about 6 to 8 weeks after everything is settled down. The main reason is safety, but also, critically, to rule out underlying cancer, especially after a first episode, or if the CT looked a bit suspicious.
Right, the delayed look. And ultrasound. Any role.
Can sometimes pick up a superficial abscess, maybe if CT isn't readily available or contraindicated.
Yeah.
But honestly, CT is far superior for looking at the whole abdomen, checking for free air, deep abscesses. It's the definitive tool here.
Yeah.
USS is more limited. Okay, so we've done the workup, we've staged the severity with CT and Hinchey. What does this mean for actually managing the patient? How do we approach treatment based on this? Guided by those ACPGBI and NICE guidelines, of course.
Right. Let's start with a more common scenario. Uncomplicated diverticulitis. We're seeing more outpatient management now, aren't we? Ambulatory care.
We are, definitely. For mild, uncomplicated cases, patients who are otherwise well, can drink, don't have major systemic signs, no significant comorbidities, outpatient is often preferred. It's cost-effective. Patients prefer it.
And what's the typical plan? Antibiotics, diet.
Yeah, usually a 5 to 7 day course of oral antibiotics. Coamoxiclav is common, or maybe metronidazole plus cephalexin for broad cover, simple pain relief, paracetamol mainly.
And you mentioned avoiding certain painkillers.
Yes, crucially, avoid NSAIDs like ibuprofen. There's some concern they might increase perforation risk, maybe impair healing. Stick to paracetamol or weak opiates if needed.
Okay. And diet.
Liquid or soft diet initially, then build up as symptoms settle. Clear fluids first is often sensible. It's worth noting, though, there is some debate globally about always needing antibiotics for very mild cases, but UK guidelines generally still recommend them for now.
Okay, that's ambulatories. But what if they're sicker? Systemic symptoms, can't drink, other health problems?
Then it's inpatient management, right?
Exactly. Then they need admission. The focus shifts to more support. 4V antibiotics, often broader spectrum, like IV coamoxiclav or Piptaz.
Piperacillin-tazobactam.
Right. 4V fluids are key for resuscitation. A good analgesia, but being careful with opiates so we don't mask deterioration.
And close monitoring vitals, inflammatory markers like CRP, checking their abdominal signs. We start feeding them slowly as they improve, as bowel function returns. Careful titration of support. Now, shifting gears to complicated diverticulitis. Things get more interventional here. Let's take Hinchey C2 where there's an abscess.
Okay, what's the approach?
Well, it depends on the size. Small abscesses, maybe less than 3 or 4 centimeters, might resolve with just IV antibiotics. You watch them very closely.
And bigger ones?
Bigger ones usually need draining. This is where image-guided percutaneous drainage comes in. It's a fantastic, minimally invasive technique.
Done by interventional radiology.
Exactly. Guided by CT or ultrasound, they put a drain into the abscess. It's brilliant because it can often turn a potential emergency surgery into a planned elective one later on once the inflammation cools down. Much safer for the patient. Okay, well, what about the really severe end? Hinchey III or 4-feed generalized peritonitis. Pus or feces everywhere.
Yeah, that sounds bad.
It is. This is a surgical emergency, no messing about. Aggressive resuscitation fluids, broad-spectrum 4V antibiotics, immediately and straight to theater. Time is absolutely critical for source control to save their life.
And in theater, for these really sick Hinchey III patients, the go-to procedure has traditionally been the Hartmann's procedure, hasn't it? Can you explain that? And why not just wash things out?
Yeah, Hartmann's is the classic, often life-saving operation here. What it involves is resecting the diseased bit of colon, usually the sigmoid. Then you bring the healthy end of the colon out onto the abdominal wall as an end colostomy stoma.
Right, diverting the feces.
Exactly. And the other end, the rectal stump, is sewn closed and left inside the pelvis.
Why do that instead of joining the bowel back together?
Because joining bowel and anastomosis in a severely contaminated, inflamed field is incredibly risky. The chance of the joint leaking is very high, and a leak in that situation can be fatal. Hartmann's prioritizes removing the source of infection and avoiding that high-risk joint. It's about sepsis control first and foremost.
Makes sense. And laparoscopic lavage just washing out. You mentioned that's less common now.
Much less common for purulent or fecal peritonitis. Trials showed it often didn't work well, high rates of needing further surgery because the source wasn't removed. So resection, usually Hartmann's, remains the standard for source control in severe perforation.
Okay, that covers the emergencies. But what about surgery later on as a planned elective procedure? When do we start talking about that?
Good question. Elective surgery isn't for everyone. The indications are usually discussed in a multidisciplinary team meeting, an MDT.
Bringing everyone together.
Exactly. Surgeons, radiologists, gastroenterologists. Common reasons for elective surgery would be things like a persistent stricture scarring, causing blockage symptoms.
Right.
Or a fistula, an abnormal connection, say, between the colon and bladder, a colovesical fistula causing nasty UTIs, or colon to vagina.
Okay. What else?
If you just can't rule out cancer after the acute episode, even with imaging and scopes later on, there's a clear indication. And then there's recurrent diverticulitis.
How many episodes trigger that discussion?
It's debated, but generally, if someone's had maybe 2 or more severe episodes needing admission, or multiple milder episodes that are really impacting their quality of life, then elective resection is definitely considered to prevent future problems and improve their life.
So if the MDT agrees and the patient wants elective surgery, what's the operation of choice these days?
The gold standard now is overwhelmingly laparoscopic sigmoid colectomy, keyhole surgery.
And what does that involve?
We resect the diseased sigmoid colon laparoscopically, then create an anastomosis, join the healthy descending colon down to the upper rectum, restoring bowel continuity.
And the benefits of keyhole?
Huge benefits. Much less pain, smaller scars, significantly shorter hospital stay, and quicker recovery back to normal life. It's much better for the patient experience compared to traditional open surgery.
Which is reserved for?
Really complex cases, maybe lots of previous abdominal surgery, very dense adhesions, or if laparoscopy just isn't technically feasible or safe for that particular patient. But lap is the default aim.
Okay, perfect. So finally, let's talk follow-up.
Yeah.
The acute episode is over. Maybe they had surgery, maybe not. What's the long-term plan we need to communicate?
Right. Follow-up is tailored. If they were managed medically for uncomplicated diverticulitis, outpatient or inpatient with antibiotics,
Yeah.
the GP needs a clear discharge summary. We advise the patient on long-term stuff. High-fiber diet, plenty of fluids, weight management if needed, all aimed at prevention.
And the scope?
Crucially, yes. Routine colonoscopy at 6 to 8 weeks after resolution. That's non-negotiable to rule out underlying cancer. Clinic follow-up might not be needed for a first simple episode, but definitely considered for recurrent cases to discuss options, maybe elective surgery down the line. Now, if they had percutaneous drainage for an abscess, they need close monitoring initially. A follow-up CT to confirm the abscess is gone. And because they've had a significant complication, elective resection is often recommended later due to high recurrence risk.
Yeah.
That discussion happens in clinic after things have settled. for those who had emergency surgery, like a Hartman's.
A big life change with the stoma.
Absolutely. Specialist stoma nurse input is vital. Education, support both practical and psychological, then clinic review around 4 or 6 weeks, talk about the surgery, the findings, and the big question, reversal surgery.
Joining the bowel back together.
Yes, the Hartman's reversal. But it's a major operation itself, with risks like an anastomotic leak. It needs a careful patient selection, detailed discussion. It's not always possible or even wanted by every patient.
Right, it's a shared decision.
Totally. And finally, after elective surgery, like the lap sigmoid colectomy,
Yeah.
usually a clinic checkup at 2-4 weeks post-discharge, check wounds, recovery. Long-term, they're usually discharged back to the GP. Recurrence after a good resection is uncommon, thankfully. Aim is to get them back to normal life.
Okay, wow. We have covered a huge amount of ground there, from that initial A&E presentation right through to complex surgery and long-term plans. It's definitely a complex area.
It really is.
Yeah.
I think the core message, though, is that diverticulitis management in the NHS is pretty structured now. It relies heavily on accurate CT diagnosis, clear severity grading like Hinchey, and a tailored approach. From simple ambulatory care right up to major surgery. And that MDT process is key for optimizing those complex decisions. It's real teamwork, ED, radiology, surgery, stoma nurses, GPs.
Absolutely. So for you, the listener, the doctor or surgeon dealing with these cases, hopefully this deep dive gives you a clearer roadmap, the essential insights for managing these patients well, understanding the why behind it all.
And maybe a final thought to leave people with. As technology keeps improving imaging, AI, maybe even understanding the microbiome better, how might these things refine our approach even more? Could we get even more precise, more personalized care for diverticulitis in the future?
Fascinating question. Definitely something to think about.
Food for thought.
Well, thank you for joining us on this deep dive. Until next time, keep diving deep into the knowledge that matters.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.